The Hageland's prominence is removed. Prepare the bone for insertion of the two 4.75 mm swivel locks by drilling down to the laser line or to the shoulder stop when using the drill guide. The hole is created 1 cm proximal to the distal insertion of the Achilles tendon. Use the tap and insert to the laser line. The 4.75 mm swivel lock loaded with fiber tape is inserted into the proximal hole. The eyelet should be placed completely in the drill hole until the anchor body makes contact with the bone. Hold the thumb pad steady and rotate the driver handle in a clockwise direction until the anchor body is flush with the bone. Repeat for the other side. Pass the needle attached to the fiber tape through the Achilles tendon on each side. Prepare the calcaneus distal to the Achilles tendon insertion. After cutting the swedged portion on each proximal anchor, retrieve one fiber tape tail from each proximal anchor, one blue and one white-black, and preload them through the distal swivel lock eyelet. Adjust tension of the fiber tape and insert the swivel lock into the prepared distal bone socket until the anchor body contacts bone. Repeat for the other side. Cut the tails.
Good evening, everyone, and thank you for attending today. My name is Karan Malhotra, and I'm one of the foot and ankle orthopedic consultants from the Royal National Orthopaedic Hospital in Stanmore. This is the BOFAS Lectures of Distinction webinar series, and tonight's lecture is going to be given by James Stanley from York, and it's on the Achilles tendinopathies. This talk is sponsored by Arthrex, and you just saw a video of their speed bridge procedure, which is one of the treatments for excision of Hageland's and the treatment of insertional Achilles tendinopathy. Now, we're going to start off today a little bit differently than usual, and we're going to start off with a poll. Just to get everyone thinking, and we're going to repeat this poll at the end. It's all anonymous, so please do answer. And I'm going to start the poll now. So hopefully you can all see that, and we'll just look at this for about 30 seconds. So the question is, the most likely successful treatment for a chronic non-insertional Achilles tendinopathy is, so either is it going to be rest, ice, elevation, compression, and NSAIDs? Is it going to be physiotherapy with eccentric exercises to try and cause micro damage in the tendon? Is it going to be injection, which is either PRP or steroids? Is it going to be shockwave therapy? Or is it going to be surgical exploration and debridement? So about 60% of you have voted, so I'm just going to give it a few more seconds. Okay, I've got about 75% voted, 80. So go ahead, closing in 5, 4, 3, 2, 1. Right, so there we go. I'm going to share the results. So hopefully you can all see those results, which you can see that 68% of you have said physiotherapy with eccentric stretching. No one thought about steroids or PRP. 9% thought shockwave, and 18% thought surgical exploration debridement. And that's just good because we wanted to set the scene and see what people's thoughts are. And just for interest, we'll repeat that at the end. Now, I'd like to introduce James Stanley, who's a consultant in York, and he's been a consultant for 10 years. He has been, and his team have been one of the early uptakers of MIS surgery and alternative forms of conservative management in Achilles tendinopathy. And in York, there's a large cohort of weekend warriors who get a lot of Achilles tendinopathy. So he really is well placed to be able to deliver pearls of wisdom for you all today. And I'm really looking forward to his talk. Just some housekeeping. We're going to first do the talk, which will be about 30 minutes. If you feel that there's a pressing question which you want to speak to, ask about, type it in the Q&A in the chat, And if it seems pertinent to what he's saying at that time, then I might interrupt him in the middle and ask the question on your behalf. Otherwise, we'll do that at the end. If we have time, we might also do a case discussion afterwards to talk about some other parts of treatment. So without further ado, James, I hand over to you.
Well, thank you so much, Karen. I'm very grateful to BOFAS for inviting me onto this talk, and I do hope you guys get an awful bit today. We're obviously aiming this much more at doing FRCS rather than me giving you the detailed science behind it. But honestly, you could spend hours and hours just talking about the Achilles tendon. It's that big a subject. Now, from my point of view, I'm going to crack on straight away, if I may, with my PowerPoint. So can I just confirm that that's come through on your screen? Karan?
Not yet.
Let me try that again.
Yep, I can see your screen now. But
How's that?
yeah, perfect.
Excellent. Okay, well, thank you again, and I must thank Karen for taking up his evenings to help us out with moderating this, and my good friend Tim Williams, who invited me on behalf of BOFAS. Now, it's interesting that we're talking a bit about the intervention of Arthrex as a sort of sponsor on this. I think it's quite apt. Actually, for the majority of my talk, we're not necessarily going to be using anything they use, because I think we have to first of all really define what's going on. So as an introduction to you, I would really want us to start with what is an Achilles tendinopathy and why do we use such a phrase for it. The anatomy for the Achilles is extremely relevant when we're talking about why you get one. I think it's quite a common question in terms of exams, because relevant to why does it rupture? Why does it get a tendinopathy? Why does it not get a tendinitis, for example? Why would you have a heel bump? Why would you do all these things? So it's very specifically anatomy related. But on top of that, you can then translate some of that information into ruptures, for example. So why do we get a rupture in certain ways? Plus also Achilles lengthening. So if you're going to do some surgeries in maybe normal tendons that you're doing for other reasons, you'll understand why you do it like we do. So the pathology, again, causes it and what changes happen inside the tendon is very important. I think investigations are a cracking topic for us to have a little chat about, because it isn't the same as we do for everything else. It just isn't. Next up, this is the one that's going to be a massive contentious issue in terms of what do you do, is you will all hopefully work with someone that does a little bit of this, is that everybody has their own way of doing it and everybody has a different theory of why it works. So I'll go through those. I'll go through my treatment algorithm and what we've had a lot of success with up in York, and then we'll talk around surgery and the various options for that, plus kind of really the theories about why you would pick one over another. And then in the conclusion section, hopefully you've learned something, but you'll probably all come away saying it's as confused as ever. And as I say, we do have a case study if we have time at the end. So it's just really, I hope to get a little bit of interaction from some questions from you guys. So what is tendinosis? Okay, this is ignoring the fact it's Achilles. This is tendinosis anywhere in your body. It is a degenerative process. I often quote to my patients, it's an aging process. You're unlucky that you're over 30. As you get over 30, we generally start to change how our collagen works in our tendons, and it becomes degenerate. It's definitely more common in obesity and in overuse. So it seems to be a trauma-related problem, but there are lots of other causes for it, i.e. quinolones such as ciprofloxacin. I've definitely seen that, where a young lady came in with bilateral Achilles tendinopathy within I'd say within 24 hours of starting ciprofloxacin. It was incredibly disabling for her and very, very painful, but it did pass eventually, but it takes a long time. Full understanding of exactly why, we don't know. Why does one person get it, another not? Endocrine disorders, okay, so this is where you'll see this one and forget. So that's your diabetes, that's maybe even something like oral contraceptive pills. All those things will contribute to it and are well worth asking in someone who's got an Achilles tendinopathy. Of course, there's genetic predispositions in there. The fundamental cause of this is probably something to do with the injury and healing response cycle. Now, I'm not talking specifically about why you get the injury. I'm just saying is that there seems to be an abnormal response between which ones kind of winning. I've often described it to patients as that the internal architecture of the tendon is a little bit like strands of spaghetti, and some of those spaghetti and they're not healing, or rather they're healing in the wrong way. So there are lots of things which I'll go through in a few minutes to explain that in a little bit more detail. Ultimately, though, the tendon becomes less springy. So it's got less elasticity to it. It's got some cross-linking between the tendon collagen fibers. I mean, a classic diabetes problem anywhere in your body is that, where you get these sort of proteoglycan forming problems. But you're even in a normal person, you will find that there is not normal collagen linking. That collagen disarray really means that when you're under the microscope looking at parts of the tendon, it's not got the normal lined up collagen fiber and fascicles. We see swelling. Why does it swell? That's really interesting. It swells because there is an abnormal balance between the numbers of cells, the numbers of collagen fibers, and the amount of water. And then this last part here, this neovascularization, is really important because we use that an awful lot in conversations nowadays, which is that the vast majority of tendons have no blood vessels in the middle of them. And yet when we get a tendinosis, we seem to start to form them. And that conversation is important because we don't know if that's helping or being unhelpful. What I can say is that inside there, the conversations, again, this is the only sciencey bit I'll try and give you because I don't find it interesting myself, let alone anyone else, but metalloproteinases, that's about the only word you're ever going to have to remember with this one, are altered in there. Now, the reason that that has become a topic is because there are some treatments that we can give that affect metalloproteinases and therefore may alter the disease process. And the last thing is that there's definitely more cells in it than there used to be. Now, pain's really interesting with tendinosis because tendinosis isn't necessarily painful. So why does one person get pain and not another? And what can we do about that? Because ultimately, the tendinosis presentation to the doctor will either be that the tendon is weakened so much that it snaps, or they're coming in with a lot of pain. Now, the snapped ones we're kind of not going to cover today, and we kind of all hopefully have an opinion whether we have surgery or conservative management for those. But why are they painful? Because if we understand why they're painful, we might be able to understand how to fix it. This one here is the big question. Does tendinosis have inflammatory cells? No. So it is not a tendinitis. Now, that is partly why I haven't included distal Achilles tendinopathies as part of the true definition of a tendinopathy. If we're going to talk about Achilles tendinopathy, we're really talking mid-substance problems. When you're getting down to the distal insertional Achilles problems, they're not necessarily tendinopathic. There are other reasons why that hurts, some of which are indeed inflammatory. So you just have to be a little bit careful. You will hear a lot of people say insertional and non-insertional Achilles tendinopathies, which kind of has a very logical thing to say, but Achilles tendinosis is going to be the mid-substance one, not the distal one. Okay. So a little bit about the anatomy. We know that there are very important structures, but why are they important? Right, those muscles in the back of there are some of the largest and strongest in your body, and the tendon itself is the largest and strongest in your body. It is made up of two main muscle bellies, and they have different functions. Okay, so your gastroc and soleus don't necessarily work together or at the same time or even do the same thing. So you have to be quite wary of that when you're trying to work out some of the treatment options for that. Plus, as you'll know, when you start to think about maybe lengthening Achilles, do you do the full Achilles or just part of an Achilles lengthening? That will affect how it functions. Okay, so what is so important about those different functions relies on where the muscles originate, where they insert, how that two muscles and that tendon rotate on each other. Then we need to know why is their internal structure important, why is the external structure important, and then finally what this blood supply issue is. So I'll talk you through all of those in the anatomy. Okay, so first and foremost, the gastrocnemius and soleus are the two main muscle bellies. We've got the dual belly of the gastrocnemius, which, as you all remember, originates on the femur and it crosses the knee. All right, the soleus, as we all remember, originates on the tib and fib and does not cross the knee. Next up, the gastroc is the bigger and stronger muscle, the soleus being the smaller one. This bit's interesting. A gastroc is a fast twitch muscle, which means it's much more involved in exercise and movement, whereas the soleus is a slow twitch muscle, which means it's much more involved in posture. Okay, so think of your soleus as one that keeps you upright, and you think of your gastroc as being the one that actually helps you move. The distal insertion of these is quite interesting. Where I'm saying insertion into the tendon, obviously, rather than into the bone, is that the gastroc is much more proximal. So when you're looking at your calf from behind, that sort of, as I say, the upside down kind of wine bottle shape, where that comes in, that's the end of the gastroc. Now your soleus can go all the way down to the ankle. It really can. And we often talk about low-lying soleus muscles as being something of a problem, but they very, very rarely are. They might give you a bit of a, as we up north call it, a cankle, with a sort of wide ankle feel, but they actually aren't pathological going low. And of course, they may be protective in some way going that low as well. What we don't know is exactly what is the role of the distal insertion in terms of a tendinopathy. Okay, but I'll just let you know it does definitely go more distally. But both of them contribute around about 50% of the fibers of the Achilles tendon. Okay, now in some people you do get slightly more gastroc than soleus, but essentially it's about 50-50. I'm just going to recap for those guys going for their exams on just examining that difference of the gastroc and the soleus. If we can remember that if we bend the knee, then the foot goes up because I've relaxed the gastroc, and if I straighten the knee, I have tightened the gastroc. So with the bent knee, I'm testing soleus. With the straight leg, I'm testing both soleus and the gastroc. Now, there's this funny little muscle and tendon called the plantaris. Its function's a little bit kind of, I don't know, unknown really. Not everybody's got one. About 90% of people have got one. But I'm going to let you know about this because we do talk about it later on. It starts on the lateral side, goes behind the gastroc, and ends up on the medial side of the calcaneal tendon. Its muscle is tiny. It's got a tiny, tiny, tiny 5 to 10 centimeter long muscle belly, and it is tiny. And the muscle, the tendon itself is tiny. It goes from the medial TA and then inserts into the medial TA. Okay, so it's the tendo Achilles part of it, it's medial. The muscle part, it goes from the middle and lateral. Okay. As I say, 90% of people won, and the relevance of it, not 100% sure, and I'll talk to you some of the reasons and logics why that conversation has to be had if we're going to talk about Achilles tendon problems. So the last part of this anatomy, a little bit that's quite important in terms of just purely descriptive anatomy, is its insertion. Okay, so the insertion, as you can see on the right hand side, that's actually a true Achilles tendinopathy. We've got that fat swelling in the middle, but the insertion actually starts to become very, very thin and widens. So it goes from a sort of fat round tendon like your finger into a fan-like thin one with the same numbers of fibers, don't forget, and it's about 2.5 centimeters wide. Now that's only about an inch to you and me. So when you're doing these posterior approaches, like we just saw maybe with that Achilles speed bridge, you've got to have that in mind. When you are removing more than 2.5 to 3 centimeters worth of tendon insertion, you've kind of touched the whole of the Achilles. Okay, so just be a little bit careful with that. It's definitely flattened. That makes it interesting when you're trying to do repairs in that area. Okay, so if you ever see a lowish Achilles rupture, it's how the heck do you fix it? Okay, so it's not relevant to this talk, but certainly something to think about. It is cartilaginous as it approaches the bone. Okay, so it has some Sharpie's fibers, but some of it's cartilaginous. And that's relevant because it can become calcified, okay, like all cartilaginous tissues can. And that is relevant if we're talking about an insertional tendinopathy or pain in the distal insertion, okay. It inserts lower than some people realize. I suspect most of you know this already, but even radiologists sometimes send me reports back describing the insertion as actually being on the top of the calcaneum there, not as far around the corner as that arrow implies. Okay, so it goes down further than you might think. It does have a mechanical advantage doing that because as our heel starts to come downwards, the calcaneum pushes the Achilles away from the center of rotation, therefore increases its power. So it's a sort of a cam effect, as we refer to that. It also means that there are other little bits in there, like there is a bursa now. So to stop that tendon attaching to the bone, there is a bursa full of some fluid. It becomes very relevant because, of course, that can become inflamed and painful. You remember what we said? Achilles tendinopathies are not painful, but pain in this area can be. Sorry, not painful, are not inflammatory, but around this level they can be. Okay. So Achilles, what's next about this interesting thing? So we know where it starts, we know what it's made of, is it twists, okay? So it's got about 90-degree twist in it. So the fibers of the gastrocnemius, particularly, obviously both of them together do this, but they start on the dorsal or back surface or the most superficial surface, whichever way you look at it, and they twist around to the lateral side, okay? So we're remembering this twist, and that twist creates a tension or stress within the system that's around about 2.5 to 5 centimeters-ish from the insertion, okay? So you can remember those numbers, I just remember, say, 5 centimeters above is pretty easy because we're going to talk about another 5 centimeter issue in a few minutes. Now, that twisting, think of it as like you're trying to wring out a dishcloth, okay? So as that muscle contracts, that tendon will want to twist even more, and within the structure, it will be under a kind of twisting like it's going under a dishcloth getting wrung out, okay? So the internal structure goes under a lot of stress because of its twist. However, that twist allows for a certain degree of laxity within the system. So it allows for there to be a strain element to this, okay? So if you understand your stress strain, I'm talking about the length change, the strain will change. So it allows for the tendon to go from a twisted to a slightly straighter position, i.e. lengthen without snapping. Okay, so that's why we think it does it. So what's on the inside of a normal tendon? Okay, so the vast majority of a tendon is made up of water, about 70%, okay? The next most common thing is collagen by far, okay? So it's mostly type 1 going up and down there, and they form little fascicles. So if you look on your right side there, that ultrasound, you can see those little lines, as it were, of all those fascicles lining up. And in the bottom picture, you can see that in cross section. Now that is about as detailed a picture as you will ever get from any form of investigation when you look at an Achilles, okay? So ultrasound is great. It is full of elastin, about 2%, okay? So it's reasonably springy. That does change to some extent with age, and it does change a little bit with genetics to some extent. So you'll find some people are slightly springier than others. Now, if you have too much spring in there, you can't put the force into the calcaneum, okay? So that's why it's not too big. Animals like camels, believe it or not, have got a lot more elastin in it, and that means that they just basically bounce along on a spring on the back of their heels. And they don't do much muscle contraction, okay? They just do a little muscle contraction to get it going, and then they just bounce and spring along. Humans don't. We need a muscle contraction for pretty much every movement. Now, this little fact is not that useful in terms of giving you an exam question, but I think it's useful to sort of have an idea that if your Achilles tendon on the inside has got all these collagen fibers lined up, they actually start wrinkled. And the Achilles has to lengthen about 2% before that wrinkling all irons out and they become straight again. So if you take a tendon from a complete resting position and then suddenly force it, it has about a 2% length before it starts to get much stress in it. So it's like that sort of early toe, as it were, on the stress strain curve. So that's important because it's the way that we see people rupturing tendons is that they suddenly do something, and that power and that force gets a kind of a momentum, 2% lengthening, it suddenly becomes 8% lengthening and it snaps. It can cope with up to 4% or so and return to its normal wrinkled state quite easily. Okay, so think about that sort of 2 to 4%-ish. Now, inside the Achilles tendon proper, okay, so inside that main bulky finger-like structure, there's not that many cells, okay, there's a few tenocytes, but not too many. There aren't really any blood vessels, all right, so we don't really see much blood vessels going down. We certainly don't see nerves with that either. What we do instead is we see the nerves going with the paratenon and them kind of stopping somewhere near the muscular tendinous junction. Now, for me, I think that's quite important to kind of understand, because if you look at a patient who ruptures their Achilles tendon, snap the damn thing in half, okay, that's a pretty large trauma. It produces a blood clot, it's damaged stuff. It actually only hurts for a short period of time, and then after that, it doesn't really hurt. If you ask someone who's ruptured the muscular tendinous junction, it hurts for bloody ages. So you'll see there, the trauma isn't necessarily any different in terms of the amount of damage, but the amount of pain can be very different. And I think that's quite important to know also, is that why aren't we having lots and lots of painful tendinopathies of the Achilles turning up? I will routinely examine the Achilles when you're looking at other things like a forefoot pain, and I don't infrequently find an element of fusiform swelling. And the patient may say, yeah, it hurt for a little while, but it's gone now. And they remain swollen why it doesn't carry on being painful. Again, we can debate that later on. Now, the external structure of this tendon, okay, so it's got no synovial sheath, okay, some tendons do, some tendons don't, so it doesn't really have any synovial fluid around it. It does, however, have some loose areolar tissue and lots of elastic fibers, a tiny bit of fluid, and that helps it slide, okay, so it's not actually got a huge amount of gliding distance because it's quite a long tendon, so per centimetre it's not gliding so much. But that loose areolar tissue shouldn't be stuck and glued to the tendon. All right, so in a normal tendon, you'll find it's quite separated. We don't have any nerves and tendons with blood vessels in the tendon. We have them in the paratenon. So blood supply. You'll often hear this phrase, the watershed area of the Achilles. So I was taught years ago that the blood supply comes down from the muscle and comes up from the bone, and that's why you've got a watershed. It's not actually 100% true that. There is definitely blood supplies that are going in that way, but actually your tibial vessels have a contribution from the lateral side, sorry, from the medial side, and your peroneal tendon vessels will have some into the paratenon from the opposite side. Now, all these blood vessels will come into the ventral surface, okay? So they go on top of the tendon under the skin, they go deep on that ventral surface. That becomes relevant because when we're going to talk a little bit later on and how do we maybe affect some of those blood vessels into the tendon, we're going to be talking about ventral surface problems, not dorsal, okay? So we're going to go now, what is specifically these tendinosis? As we mentioned earlier, it's definitely a degenerative process. It's definitely stiffening with some cross-linking. I think it's definitely an abnormal injury and healing response problem. It does present with swelling. It does present often with pain, even if not everybody has the pain. And we are happy to say there's no inflammatory cells. Now, if you want to take that another step further, is there such a thing as an Achilles tendonitis? Then the answer to that is probably yes. You will occasionally see a patient who has a very short history of an Achilles pain from a traumatic overexertion or traumatic injury, particularly in younger people, and they generally settle quite quickly. That's a different problem to what we're talking about, which is the chronic tendinopathy. So what is it? So we said it's all of the above, but it's now in a very specific area, and we're talking about that 5 centimeters or so above the insertion. Okay, it's there because of the blood supply, the twist. It's also there because it seems to be where the most stress is put into the tendon. All right. The pain part of it probably is coming from the paratenon side of it, although some of the sort of ingrowth of these blood vessels may well, this neovascularization may be dragging nerves with them. And so the neovascularization is probably important, but we don't exactly know why. All right. It just implies that it's trying to heal. And we know that inside of the tendon, okay, not the external surface here, the internal surface. If you look at the outside of one of these tendons, or if you ever operated one, you'll see that the outside's kind of silvery and still has that collagen fiber lineup. Okay, it's got that striation look to it. Whereas if you look at the inside of it, it kind of goes white rather than silvery yellow, and it looks like very homogeneous. There's none of that lining up of stuff, and it just. I used to use this phrase mucoid or myxoid degeneration. Is that kind of feeling that it's not right in there. All right. You can get fatty deposits in there. You can get vacuole deposits where there's a little bit of fluid and stuff, and they're typically a little bit more age-related. All right, so when you see people a little bit older, you'll see those, and they're not necessarily painful either. Those ones, and you can get the odd one where you get calcium pyrophosphates in them, and I think post-traumatic, certainly from young age groups, you sometimes see a lot of calcium deposition in those as well. So how are we going to present these papers? I'm going to sort of examine them. So. Look at it thing. We've always said that, haven't we? It's not particularly difficult. They're going to come to you with their pain, swelling, and activity-related issues. What are you going to do? You're going to go through the basics of look, feel, move, special tests. And I think it's quite important when you're getting into your exams that when you're under that huge amount of stress, okay, the exam's a miserable experience for most people, is that when you're given the can you examine this person's leg, and it's a really weird shaped leg or something, you can find yourself quite quickly getting distracted by the weird shape and completely forgetting to look at the skin. So we always recommend, I do anyway, recommend you look at the skin, you look at the tendon, and you look at the bony deformity, and you mention all three, okay? So it's easy there. So if you look there, then we would be looking at, there is a fusiform swelling with no skin changes, okay? You shouldn't see skin change. You might see the odd one with thickened skin from rubbing, but you shouldn't see any obvious skin changes. We then feel it, all right? So typically as you start to massage down there, I always start proximally. So I'd work around the gastroc heads, work my way down the tendon, be very specific about when you're pinching it, which side does it hurt on? Does it hurt on the left or the right or the medial, the lateral? Okay, so you've got to give that patient that information. And the reason for that is they nearly always hurt more on the medial side. Okay, so another thing for us to remember there. So it's 5 centimeters above with a form swelling. It's on the medial side. We're then going to do all the way down. We're going to look at the insertion, calcaneal squeeze test. We're going to do all our distal, neurovascular examinations. And we're going to make sure that we've given that the full overhaul. All right, so we've pointed out the obvious bit. Moving it, well, that's really doing that Silver-Schultz test as much as anything else and testing the power. Is it in continuity? Isn't it in continuity? And then when we get down to the special tests, really you're going to be doing your bits depending on what you think is the problem here. So, for example, if you think there might be a rupture with some healed tissue that's caused this, then you'll want to check the length and you'll want to check whether there's calf squeeze. If you've got some more distal pain and a valgus heel, you might want to be doing a tib-post type examination. So just be aware that they may throw you a little bit with an Achilles problem, but actually it's been driven by another problem such as a flat foot. All right, so just be careful with those. What's our differential diagnosis? Well, we're going to start at the top, the tennis calf or the medial calf problem, okay? So typically the medial one's the bigger one of the two. It goes a little bit more distal, and that's usually the one people injured, okay? So that muscular tenderness, head of gastroc, those patients are normally quite painful actually, and they often have a very specific area when you examine them that says it's there. If you're not sure, by all means get an ultrasound, okay? Achilles ruptures. Now, typically they present with a sudden onset pain, as we all know, and then it sort of doesn't hurt that much. The ones that come to you late with the GP will write to you saying there's a chronic problem, this gentleman's Achilles, it's bothering him and he doesn't have as much power to push off as he wanted and it hurts. And then you examine them, you often find that they've got a missed presentation of Achilles rupture. Sometimes you feel a gap, sometimes you just feel scar tissue. So just be wary of that one. The insertion lengthosopathy at the bottom end, okay, so that's the one that comes into you and says, yes, my Achilles hurts, and it turns out that it's not their Achilles, it's actually their calcaneum, okay? So what we would do to say what is the difference in terms of examining the sort of distal part is that if it hurts when you press bang in the middle, so the midpoint of the heel, and you're going to press onto where it's inserted, if that hurts, that's usually an insertion lengthosopathy. It's a good rule of thumb. It's not 100%, but it's a pretty good rule of thumb. If you're thinking, I wonder if it's the retrocalcaneal bursal area, so this little pocket of fluid behind the tendon, then I generally pinch. So I pinch either side of the tendon, and that puts a lot more pressure purely on the bursa. And that seems to be pretty reliable because some people come back and say, yeah, that's agony, but the insertional part isn't. And then we've got the calcaneal stress fractures. Again, they can present with some unusual heel pains or Achilles pains, and that's more of the calcaneal compression or squeeze test. So you're going to give the calcaneum a good squeeze between the butts of your hand, okay? They're all very, very useful to know all of these tests, okay? And the plantar fascia one, again, is more underneath. And I don't want people to get too bogged down ever really with what is the relationship between the plantar fascia and the Achilles, okay? Because yes, in the embryo they come from a similar thing and all the rest of it, but actually in reality they both attach to the calcaneum and they are not in continuity per se. So it's, although treating one might help the other, it gets a very confusing and big picture. So I generally say to someone, don't get too bogged down with that and try and think of them as separate entities. We've got the posterior ankle impingement ones. Again, they're going to be a little bit deeper and they're going to be position specific. So that's the one where if you force them into a plantar flexed position and you kind of flick it down, as it were, they go, ow, that hurts at the back. Of course, the treatment for that is to say, oh, don't do it anymore. Most patients would say, oh, thanks. Occasionally dancers and footballers do want some treatment for that. So we now know what an Achilles tendinosis is. We've examined them and we've hopefully excluded some of the other things. Is that we now want to know, how do I investigate this? I'll be straight with you. It's a clinical diagnosis. Most of your investigations are adjuncts. I think you can pick up the vast majority of these in the clinic. So yes, you've got Achilles tendinosis. I will prescribe you the various treatment options. You don't need to dive in with lots of very expensive scans. What we do scan is the ones where we are confirming the diagnosis when we're going to go into surgical procedures or we're unsure of that. presentation for any reason. So if we're worried about something, it's a funny shape, it's too much pain, it's an odd colour, then I definitely would. Or somebody that's failed conservative management, then you might start to scan those. Next question is, do you do the ultrasound or the MRI? You need to know this, okay? The MRI scans are going to show you a kind of thickened or fusiform shape to the Achilles. What they don't generally show you is inflammation, okay? Because there isn't any. So there's not normally a huge amount of water in them. And you can have actually very, very subtle Achilles tendinopathy, and the MRI basically comes back normal. Your report might say just there's a mild thickening. It doesn't tell you how bad it is. It doesn't really tell you what to do. And I don't necessarily do MRIs very often. Now, that's very different to the distal insertions, okay? When I'm doing those distal insertions, an MRI can be very helpful because we do have inflammation problems down there. The ultrasound can be very useful because not only does it show me the widened tendon, I can measure it, but it also shows you with a Doppler the neovascularization. So I've given you very specifically a cross-section there to show that that is coming from the ventral surface or the deep bit. Goes up into the tendon. You don't get that if you don't have a tendinopathy. Easy, remember that? Okay. Other things that you can find on the ultrasound that are very helpful is that we can a little bit of the paratenon where that letter A is, but we can also see inside the tendon. Now that you can't do on an MR, okay, it doesn't show you this very well. You can see little vacuoles, little tiny pockets of fluid, little areas where it seems to be going through a rapid turnover. That's the areas of B. And you get that abnormal architecture, which is the C. When do I x-ray them? I never x-ray an Achilles tendinopathy. I will occasionally x-ray the distals. Okay, so I say occasionally, you probably do them more often than not. What is the theories of our treatments? We mentioned this neovascularization. It's definitely an abnormal feature. Do we stop it or do we increase it? The concept there really is that neovascularization is bringing in nerves and an abnormal healing response. Therefore, if we stop it, we'll get rid of the pain, the nerve response, and theoretically the healing will all slow down. If we increase neovascularization, which is another theory, is that I'm now going to bring more blood supply into my damaged tissue, and I'm going to make that tissue heal better. All right, so you've got those two options. Another theory, do we reduce injury? Do we rest that tendon, give it a little gentle massage and tell people to stop doing activities? Or do we stimulate healing through giving it more injury? And that concept, I think, has been fairly well described by a gentleman called Ledbetter over the years. And we've all more or less followed that stimulating it is probably the better way of doing it. So when we were talking earlier about the physio exercises are deliberately eccentric. Okay, so for your benefit, that means you put your heels on the edge of a step and you drop down. Okay, and we're doing a deceleration but under force activity, so we're lengthening it whilst under contraction. And the reason that's helpful is that your body generally cogwheels that a little bit more, so it's more of a juttery kind of relaxation, as it were, or lengthening of the tendon than trying to do it the other way. As that happens, we are causing micro injury within there, and we're trying to stimulate a normal healing response. That's the concept. Next one, where are those nerves coming from? Do we want to decompress the tendon and make the tendon smaller? Would removing that diseased tissue on the inside help? Makes sense, doesn't it? We've got this myxoid, mucoidy stuff. Does it help us getting rid of that? Or do we want to decompress the paratenon? Do we just want to give this fat tendon as much room as it needs? That one we don't know for sure. There's lots of logic to one or the other. The decompressing the tendon probably decompresses the paratenon as well, doesn't it? Because we've taken the stress off it. If we just split the paratenon, we may well be helping with pain by just giving it more room. So we're helping with those stretch receptors. And then the last question is, does dividing the plantaris make any difference? There are people out there that swear by the plantaris phenomenon, saying you probably can't get an Achilles tendinopathy without a plantaris. The plantaris tendon, as we mentioned earlier, is on the medial side of the tendon. We've mentioned that the blood supply is probably one of the worst, around the 5 centimeters on the medial side. And we've also mentioned that about 5 centimeters up, there's this fantastic twist in the tendon, again, causing the soleus tendon, which has got slow twitch fibers going down the medial side. So there's lots of things on the medial side, but one of them is the plantaris. So if our patient's presenting with a medial problem, it could be that the plantaris is causing that issue. If you want to have just a very quick conversation about that, it is possible to divide a plantaris in isolation. I know that James Cole's recently wrote a paper about putting a percutaneous needle under ultrasound guidance and just cutting the end of it with the tip of the needle. There was a gentleman called Nick Van Dyke in Holland when I went for my course there some years ago. He was talking about doing it arthroscopically, just removing it and cutting it. A good colleague of mine, Mr. Jarrett, works with me, has done a paper showing that they removed the plantaris and did some ventral surface Achilles stripping, I think it was called, or scarring or something. But anyway, they did some work to those neovascularizations and they had great results. So the plantaris, is it an evil, horrible thing or not? I don't know for sure, but there are people out there who believe it is. And then, of course, we can always theoretically treat this by adding meds which are going to alter some of those cellular responses, particularly those metalloproteinases that we mentioned, but also maybe the neovascularization. So I've seen, certainly we had a pretty adventurous physio with us who was using GTN patches and was saying he was getting some good responses with that. But there's various different ways you can do that. And I'm not going to go into any detail on it, only because I don't think the evidence is brilliant for any of them. So what is the conservative treatment? It starts with physio. So we mentioned earlier, do you let them rice it? No, it's not inflammatory. Do we give them non-steroidals? What's the point? It's not inflammatory. What we should probably do for them is get them the physio, and the physio will be eccentrics. Now, I'm going to give you a little word of warning there. You will find there's an elderly age group, and I won't define elderly in case there's people who are over 50 here, but if you get an older population, they can often find that the eccentrics make them worse. And so do ask them, do you find doing eccentric exercises makes you worse? Because if they say yes, tell them to stop doing it. And try and do some more stretching type exercises. It just seems to be an odd group of people that do benefit from that. And the problem is that often you'll have very, very diligent patients, because doing eccentrics is quite easy. It's on the way to bed, it's on the way back home in the morning. So eccentrics are quite easy going up and down stairs. So physio, super important. Heel raises, okay, so what's the concept of the heel raise? It's just to take a bit of tension, okay, it's a bit of that stress out of the twist by putting us in a marginal equinus position. So yeah, heel raise, is it the cure forever? Probably not. Is it a good idea to help you whilst you go through a recovery phase? Why not? It kind of goes against, to some extent, what we would be doing with eccentrics, which is stretching stuff out. Most people would do heel raises, but just be aware of it. Do heel raises both sides, and it's usually about 1 centimetre or so. Acupuncture, or some needling of the tendon, is definitely popular. It's definitely got its place, and the concept of that one is really to cause microtrauma somewhere. Okay, I know acupuncture has other roles, but we've done quite a lot of acupuncture sort of type work and found that patients did find it helpful. This extracorporeal shockwave therapy has certainly become quite trendy in the last few years. We were one of the early uptakers with that one, and I'll explain in brief what it does. You put a probe which has essentially a metal bullet in it, but instead of the gun with this bullet in having a hole at the end, it doesn't, it has a blank plate. So that bullet hits the blank plate and it transmits the shockwave into the tissues via the jelly. What that's going to do is, if it does it fast enough and hard enough, is it shakes that tissue till it forms little bubbles of air, which last, or bubbles of gas, which last a very, very small period of time and then quickly resorb again. That's going to split these abnormal crosslinks. It's going to split some of the neovascularization tissue. It's going to split some of the nerves. All of those are theoretical and nobody really knows. Okay, we know that it causes some form of trauma. We know it causes some form of trauma in the tendon. And interestingly, it's not necessarily a system in which you're forming these decavitations. When you look at how it actually works with some of the radial ones, they just shake it quite violently rather than actually form these little vacuoles. So just be wary of it. It is a great, very commonly used adjunct, particularly in the private practice circles. It's a real shame that certainly in the UK you can't get it on the NHS very often because it's definitely got a role. And there's lots of papers out there now that say it. PRP, or platelet-rich plasma, very trendy. This one is the spinning down of blood to get platelets. Platelets are full of growth factors. If I inject growth factors and helpful healing proteins into a diseased bit of the body, it should make it heal better. That's the concept. We do it for mid-substance Achilles, but it's not Brill. And I think what you have to do is actually needle the tendon as you do it. So you actually have to cause trauma to the tendon, and then maybe the PRP does something. But it's not, I personally don't have great experience with it. I don't think shockwave or PRP works with the distal stuff. So if you're talking insertionals, don't do either of those. There's no evidence for them really, and they just hurt. So this is only really for the mid-substance. We've mentioned topical GTN. It's affecting intracellular work there. We've got hypertonic sale, hypertonic dextrose. These ideas are that you inject into the tendon sheath something that's essentially a bit of a sclerosant to those neovascularizations. Okay, so it's going to make those disappear. We've got the other one, which is the high volume saline. That's kind of the idea of that one, is to inflate the tissue between the tendon and the paratenon, that loose areolar tissue. It's going to put in a huge amount of stretch. It's then theoretically going to start making things divide. So maybe if your plantaris is stuck to the side of the Achilles, it might split it off, or it may just make the whole paratenon rupture. So we've now done our split there, but it's done through a sort of semi-conservative way of doing it. There's also a little bit of contention because it often has a small amount of steroid in it. Does that help just purely as a painkiller? So there's a few bits to that. I've certainly tried it. I personally haven't had a huge amount of success with it, and the literature's a little bit hit and miss with it as well. So, but certainly in terms of low risk, it's sometimes worth a try for some patients. Sclerosants have been tried for the same reason as the hypertonic salines. Laser therapies, again, same idea. Let's remove the neovascularization. Let's burn it out. Radio frequency probes have also been tried to do the same thing. All right, loads and loads of choices. So let's keep it simple because this is what I do and it seems to work. We do the physios and the heel raisers, and we tell our podiatrists don't send me anything unless they've had at least a few months of that, unless they're absolutely awful patients for pain reasons. Okay, we go on and do some shockwave. Shockwaves, controversial, I get that. We do have access to it on the NHS where we are and privately, and I quote to the patients around about 2/3 will get better with that alone, as long as, and it is really, really important, they do their physio. What it is not in exchange or instead of the physio. Okay, so it's an addition to. If we add in a bit of acupuncture to that, or a little bit of needling, it seems to work reasonably well. It's done once a week, about 6 weeks. Although I'll be honest, I stop at 3 nowadays and wait 6 weeks. So I normally do for 3 weeks, then say to the patient, look, you're not going to be perfect yet. Let's see you in another 3, and they seem to get better. We can always repeat it. Next up, if it's not working, we do go to the PRP. Why? Because there is definitely around about 50% of those that are left seem to be getting better with PRP when we put it in our hands. I totally get that there is maybe a placebo effect of the fact we're sticking a needle through the tendon and adding P, but it's a local anesthetic procedure. It's a reasonably quick thing to do, and we do it. Now, be careful. I know in the literature it talks about local anesthetics and PRP being an issue. I'm not sure how true that is, but we definitely use it. So what's next? Well, do we do surgery? Very, very rare. When I was preparing for this talk, I was trying to find a case of when I last operated on one of these, and literally in the last 5 or 6 years, I think I've done 2. And if I told you I see at least 1 or 2 of these a week, because we've got the shockwave therapy and a reasonably good physio setup, we attract quite a lot of patients around the regions, and we just seem to operate on so few of the mid-substances nowadays. But if we do want to operate on it, we have to know what we're doing. So what's the options? We've got damaged tendon. We can decompress the tendon. We can reinforce the tendon. We can decompress the tendon, or the paratenon, sorry, or we can divide all those adhesions. We can do tomotomies, and we can lengthen the tendon. So they're all the options, okay? So don't think that you have to do one or all of those, but it is perfectly reasonable to. Some people just do a tenotomy. Some people do a gastroc lengthening. There's a new paper out there that suggested that was good. Some people do the adhesions, okay? I think if I get as far as surgery, they're normally pretty bad, so I do a bit of everything. I do the midline posterior approach. I'll divide all of those adhesions. If there's a plantaris there, I get rid of it. We then do a split. Where's that gone? We do a split the deep paratenon surface. I then open the tendon. I decompress it by removing the core. I reinforce the tendon then with some ethibond, and then I close it all up. And it doesn't take too long to do all that, believe it or not. But it does need to be done in a way in which you're very, very careful with the skin. All right, I can't tell, my registrars will tell you, it's just so frustrating seeing someone squeeze the skin with forceps, because you just know that's going to cause problems in the longer term. Try and do it on a banana, and you'll know exactly what I mean. Right, excise the tendon and do an FHL transfer. This is the last bits that really for you guys, which is, yes, you can do a salvage procedure of saying, well, the Achilles is shot, I cannot get this thing better. Let's just remove it and then do an FHL transfer. How often are you doing those? Extremely rare. Okay, and it's normally for people who've got multiple level pathologies, such as a mid-substance with an insertional, and you just can't get on top of it. Just very briefly on that distal end part, because I know arthrex had been mentioned earlier, that surgeries that you're talking about there is only for the distal end. Okay, you might add it in if they've got a multiple level problem, which are rare, and they're normally an older age group, but just to warn you about that. So to conclude, the anatomy explains the disease. So we need to know the anatomy, we need to understand it. The disease is degenerative, okay, it's an aging thing, it's not inflammatory. The vast majority you shouldn't operate on, okay? As tempting as it is and as keen as the Australians are, we generally try not to do too much of that. We have lots and lots of theories of why treatments work, and we have physio at the core of all of them. Never forget it, okay? That's really, really important. So theoretically, we are now sorted. So I'm going to end the talk there. And I know it's been a sort of a fairly whistle-stop tour around the Achilles. I'm very happy to talk a little bit about the distal stuff as well if people wanted to, but I'm also aware that it's Christmas and you guys probably want to have time with your families and things, but I did like this one was sent to me recently, which is what's the name of the Christmas song? It's the Missing Toe and Wine by Cliff Richard. Mistletoe and Wine for those who don't know that one. Right. I'm going to quickly just turn off my share screen here and then ask Karen to come back in if you wouldn't mind.
Yep, I'm back. No, thank you very much, Jim. That was very thorough. I can honestly say I think I've never had this much detailed explained to me of the pathology, and you've certainly raised a number of theories. Interesting, you comment about the plantaris being almost always a causing pathology, because I had a patient once I was absolutely convinced she had plantaris as a cause for Achilles tendinopathy, medial pay, everything classic, and I sent her for a scan and she had no plantaris. So you always get the odd one which catches you out. We've got an interesting question from one of the members of the audience about your PRP injection. And the question is, when you're injecting the PRP, do you try and target the area of mucoid degeneration, or are you just kind of going blind?
Okay, so it's a great question. I'm actually going to answer your plantaris one first because it is a topic. I think that if James Calder's paper, which is doing a pure cutaneous thing under ultrasound, where he only removes or divides plantaris and nothing else, if that cures pain, then I'm going to be convinced plantaris is the. But until that happens, that paper, he's only described a technique so far. I haven't seen the results of it. If that comes out, then I will follow your lead and say yes, plantaris. But until then, I'm pretty sure it's just a red herring in the way. In terms of PRP, I inject under ultrasound guides always. I generally pre-mark a patient before I even start all this, get the old permanent marker out and examine them thoroughly for the more painful areas. We put a little bit of local into the skin, and then the PRP, we generally essentially pass the needle, for example, into the tendon. We then, as we withdraw the tendon, the needle, we generally inject a little bit of PRP. So we have to make a little channel for it. If you try and put the needle straight into the tendon and inject it, it hurts. But I think you just can't in there. It just doesn't go anywhere. There's no base per se. So what you end up having to do is put multiple needle passes through the tendon to kind of make little holes in it to get the PRP in. If I see a lot of neovascularization and things, I'm not against putting a little bit into that paratenon sort of tissue area and inflate it a little bit. It depends how much PRP you have, which system you use. Some PRP systems milliliters of fluid by the time you're finished, whereas others sort of, we call them platelet rich, but they're kind of platelet, but it's obviously more plasma than platelet. I think the Arthrex one is a little bit like that, and that gives you a lot more volume, so then you can do a little bit more. So to answer your question, yes, do inject the mucoid bit, but think clearly where it is and do make little holes in it to do it.
Okay, great. So you've also talked about a number of theories, and you've talked about a number of treatments, and you've talked about things like high volume injection and PRP and shockwave and decompression. But you personally, in sort of your experience, which theory do you really believe, and which do you actually think is the one which is likely to make the most difference?
Okay, I'd like to sort of mention to people what's the difference between a fact, a theory, and a belief. Okay, we've got tons of belief in orthopedics, and a lot of theories, and not 100% facts very often. But I think the things that we can say are facts is that it's degenerate. Okay, it's definitely an abnormal healing response in the middle of it, and it's definitely an aging process. Okay, we've got that fact. We can look at the microscope and prove it. The next stage is what has caused this neovascularization. That's the bit we don't really understand. And what I think is happening is that if we assume that there's nerves going with those blood vessels like they do everywhere else in the body, and that those are the afferents that are the painful bits, then getting rid of neovascularization will probably get rid of the nerves. That's my thought process. In terms of does increasing neovascularization help, I think what you've actually done is you've increased the trauma. So if you do like shockwave, which increases neovascularization, what you've actually done is increase the trauma within the tendon, which might stimulate a new healing response. If you ask yourself what happens with PRP, it's the same thing. So ignoring neovascularization and everything else, what I would say is it's degenerate. I want to make it start to heal into a normal tendon again, and I want to get rid of the pain. And I think that the part and the pain are separate. So if you take your pain bit, that's, I want to get rid of those nerves and adhesions and the pressure in the system. When I'm talking about wanting the tendon to heal and become stronger so that patient doesn't get a rupture, I'm talking about using the PRPs and the shockwave and things just to try and stimulate a healing response. I hope that makes some sense.
Yeah, okay, great. So we got another question here. We'll finish a few questions, and then I think we probably won't have time for the case. So when would you make a decision to do a tendo-Achilles lengthening? That's one of the questions. And I guess a follow-up associated question is, when would you do a gastroc release?
Okay, yeah, so it's the same sort of question. That's clinical, okay? So for me, if they are tight, do it. Interestingly, I was mentioning this kind of earlier, is that I think a gastroc release, unless it's done for a spasticity disorder or something odd like that, but for the normal human being that we generally see, it's just quick physio that. And if you ever look at them, they are definitely weaker in push-off afterwards. They definitely have a problem to some extent for about a year, 2 years afterwards. So you've got to be a bit careful, I think, doing gastroc or TA lengthenings for that. The role is there. The papers are there. There's a new paper out, I think Karan mentioned it to me, from foot and ankle surgery recently. And, you know, there is a role for that lengthening. But for me, if I'm lengthening, it's because I've examined them before and have a lot of tightness. Then I'll do it.
And are you doing that mostly in the more younger population rather than the older population who presumably have a slightly different disease process?
Yeah, no, I don't think age really matters to me for that one. I'm just thinking I don't do the full TA lengthening in somebody that's got an Achilles tendinopathy. So no, it would just be the gastroc, and it's a Straya type. And how often do you do them? It's very rare. If someone's coming with a really tight gastroc and I've got the tendinopathy, they're in the physio with the shockwave and they don't come near. And if they come back with still tight gastroc, I almost don't believe they've done their exercises, because you can't do eccentrics on the back of a stair with your leg straight if you've got a really tight gastroc. Doesn't stretch.
Okay, so we've got one more question here, and that is, do you see a difference in incidence of Achilles tendinopathy with planus foot or cavus foot? That's a tough one.
Yeah, no, it's a great question. The vast majority of tendinopathies that I see are not associated with a hindfoot deformity. The vast majority. I think theoretically the valgus hindfoot is a better shock absorber than the varus hindfoot. So theoretically, the varus or cavus foot is more likely to cause trauma to Achilles. That's the theory.
Okay, and the final thing, I guess we did get everyone to do a poll in the beginning. I'm not going to repeat the poll because we're out of time, but 68% said that the most likely successful treatment for chronic non-insertional Achilles tendinopathy was physio with eccentric stretches. Do you agree?
I mean, my talk was pointless because they knew it all already.
Well, that's great. So you've reinforced it. So James, thank you very much. I'm sure everyone really appreciates the talk, and thank you for taking time to answer the questions. So just some housekeeping. So everyone, the code has been posted in the chat already by Mr. Ghani. So you can use that for the normal feedback that you get. You will get an email tomorrow as well if with the code and the link to the feedback. So please make sure you complete the feedback, because once you do, you're then eligible to get the certificate with the CPD points. Thank you once again for Arthrex for sponsoring this. Our next session is going to be next year now. So that's going to be on Thursday, the 7th of January. It's on hindfoot fusions, and that's by Chris Blundell and Mark Davies from Sheffield. The registration for that is not yet on the BOFAS website, but hopefully will be in the next course, in the course of the next week or so. In the meantime, thank you all for joining and giving up your evening. It's 9 o'clock now, so good night from us, and we wish you all a Merry Christmas and a very Happy New Year, and see you next year. Thank you.
Merry Christmas. Thank you ever so much.
The Hageland's prominence is removed. Prepare the bone for insertion of the two 4.75 mm swivel locks by drilling down to the laser line or to the shoulder stop when using the drill guide. The hole is created 1 cm proximal to the distal insertion of the Achilles tendon. Use the tap and insert to the laser line. The 4.75 mm swivel lock loaded with fiber tape is inserted into the proximal hole. The eyelet should be placed completely in the drill hole until the anchor body makes contact with the bone. Hold the thumb pad steady and rotate the driver handle in a clockwise direction until the anchor body is flush with the bone. Repeat for the other side. Pass the needle attached to the fiber tape through the Achilles tendon on each side. Prepare the calcaneus distal to the Achilles tendon insertion. After cutting the swedged portion on each proximal anchor, retrieve one fiber tape tail from each proximal anchor, one blue and one white-black, and preload them through the distal swivel lock eyelet. Adjust tension of the fiber tape and insert the swivel lock into the prepared distal bone socket until the anchor body contacts bone. Repeat for the other side. Cut the tails